Good afternoon, everyone. Thank you for coming and welcome to the Prevention and Screening Multidisciplinary Rounds for the Central East Cancer Screening Program. Today we're here to talk about cervical cancer screening, and we have with us Dr. Nathan Roth, who is our Regional Cervical Screening and Colposcopy Lead and also a practicing gynecologist in the Scarborough area. And we'll also introduce from the team Caitlin Loudon. Caitlin, if you could just give a wave to the people. And we also have Dr. Mehta. Dr. Avnish Mehta is our regional family, our primary care lead for the Central East region. So happy to have him with us as well. So today we'll go through a presentation from Dr. Roth. We will have time for questions at the end. And the meeting is being recorded, so just for your awareness, we'll be able to circulate that link after if anybody's interested. We just ask that you keep yourself muted during the presentation, and then certainly feel free to unmute at the end for all the interactive questions. If you have any trouble with your mute functionality, you could also put questions in the chat, and we'll make sure to read those out and get some answers and engagement on those. So without any further ado, I'll turn it over to Dr. Roth. Thanks, Dr. Roth.
Anyway, hello everybody, and thank you for attending this event. Needless to say, cancer screening is on the forefront of everybody's mind because of its importance. And I'm not going to do a land acknowledgement, but I'm just going to talk about my surprise and dismay that it seems like every month there's another residential school that they're finding skeletons. And needless to say, as we all move forward, we have to make this right and look forward to productive solutions for the Indigenous population. Okay, next slide. So the learning objectives today are to understand the importance of cervical screening in our community. We're going to review the cervical cancer patient story. We're going to talk about a little bit about successful pelvic examinations on your patients. And if you have a moment, grab a pen and paper and talk about your challenges and your successes on patient examination for female patients. We're going to go over HPV and PAP results 101. And I want you to think of if you take away two things from this discussion today, the low risk group and the high risk group for abnormal pap smears. So every slide that you look through, think of it in that sort of dichotomy, low risk and high risk. And it'll help you understand the changing environment of HPV and cervical screening. The other thing is, there's such a value of the collaborative model that really we haven't extended as much as we should have. And who can do cervical screening? And the idea of going through delegation and using medical directives and focused policies to help support, and we call it force multiplication. It's the idea of amplifying the primary care physician to enable them to actually service their patients, and especially this time of human resource issues. So we're here today to develop authentic partnerships. Now, to have an authentic partnership, there has to be a two-way discussion. There has to be active listening. And we're here to build relationships and bring to you the valuable information that allows us to be successful in the current practicing environment. It's also the Central East's responsibility to develop the structures and processes with your collaboration and input. So without you sitting at the table and doing the hard work at the front line and providing input and being involved and actually attending these meetings, this allows us to move forward and really get to the essentials of why we went into medicine and why we want to improve health outcomes. And to be successful, we understand that we have to be able to share. And sharing authority and power is really what it's all about. And now Shannon's going to provide the background information of a patient story. And the patient story is so relevant to us because we all have stories, and we've all heard them over the years. And Shannon's going to frame Jane's story. Shannon, take it away.
Thanks, Dr. Roth. So this was a video that we put together because, as Dr. Roth said, it's really important to hear from the patient's perspective, the value of cancer screening, and the journey that can come with missed opportunities in cancer screening. Very unfortunately, Jane is a stage 4 cervical cancer patient. She's a wonderful individual, and we had the pleasure of working with her. And she was very kind to share her story and her kind of request or plea for people to get cancer screening. So I'll leave it to Jane to tell her story in the best way possible, but we have a YouTube video. I'll also just say that this is in draft form. We're working on a few fine tunes through our communications department, but once it's completely finalized, we will have this for distribution far and wide. We'd love everybody to be able to see this video and put it in front of patients as well, so that they can relate to and be empowered by Jane's message. So I'll turn it over to Jane.
Is just to are we getting the feed on this?
Can you hear it okay?
No, it's not sharing, Shannon.
Yeah, it's not running.
Sorry about that. Let's try that
That's
again.
okay.
I'm sitting here watching Jane's story all by myself. Sorry about that. 1 second here. Okay.
I mean, I'm 51. I would hate for a 21-year-old or something to have to go through digesting their own fate.
Can we adjust the volume a bit, Shannon,
Okay.
if you can?
This is what's going to take me out. I'm doing everything I can to make sure that you don't have to go through what I'm going through. My name is Jane. I'm a wife, a mother, a grandmother, a friend, a lover, a cat mom, and I am a cervical cancer warrior. Something in my brain had told me that my IUD had been in for 5 years. So I'd called, made an appointment, went in, and when I got there, the receptionist had said to me, "What are we doing today?" And I said, "Well, I need my IUD out. It's been 5 years." And she had said, "No, it's 4." And I'm like, "No, it's 5." She's like, "No, Jane, it's 4." And she turned the computer around to show me the date that it had gone in. And I'm like, "Oh my gosh. If it's not coming out, what do you want to do?" And I said, "Well, let's do a pap smear. We'll just, make sure everything's good and everything's okay." I was laying on the bed, put my feet up, and she put the speculum in and took the speculum right back out again and said, "I'm just going to wait for the doctor. Is that okay?" And I said, "Yeah, absolutely." Meanwhile, the entire air in the room had changed. It was like a wet blanket. When the doctor came in, he had done the speculum, and he was like, "Oh," he goes, "Okay, I'm going to take a sample." And it hurt like nobody's business. I have never, it was just one of those things where you're like, "Oh my, ow, ow." He said, "I'm going to send this away and see what it is." And I said, "Okay, no problem." And he said, "We should have the results back in a couple of weeks." So this was, I believe, on the Tuesday. And I'd gone back to work, and I was in a lot of pain, a lot of discomfort. So I had called and I said, "I need to come back. I need to see the doctor. Um, I can't shake this pain." When I got back to the office, the receptionist said to me, she goes, "Oh, you're here." She goes, "Your results are back too." And I was like, "Pardon?" I'm like, "Oh, okay." Like in my head, I'm like, "Pardon? What? Went in and I sat down and I waited for the doctor to come in, and he came back in and he, forced his best smile. Lovely human being that he is, forced his best smile. And he sat down and I looked at him and I said, "My results are back after 2 days, not 2 weeks." I go, "Is it bad news?" He goes, "It's cervical cancer." And I said, "Am I going to die?" He goes, "I don't think so." He goes, "But we're going to do a hysterectomy." We set up all the arrangements to go to Kingston. Joke's on me. We got to Kingston. And when I was sedated, I had an internal exam and it had spread. We couldn't do the hysterectomy. because of what would have to come out. I wouldn't have time to heal in order to have chemo and radiation to save my life. So we were going to leave everything and just go have chemo and radiation. Okay. I said to the surgeon, I don't want to die. She said, I don't want you to die. I'm not going to let you die. I said, I just got my hair done. She started laughing. She goes, your hair looks amazing. We're not going to let that happen. Off we go to Oshawa Hospital. Met an amazing doctor. A doctor that I really don't know. I don't know how I would have gone through a lot of it without my very first doctor. He did save my life. She did my radiation, and I had a little bit of chemo. They dulled it down. She did my radiation and my brachytherapy. We thought we were okay. We thought we were great. We got the all clear. Not that it was gone. I don't like to use that word. That it was just clear. And then the pain in my back took us back to the emergency room, and it was a lump on my kidney. It was there. It was never really gone. It just found a new spot to hide until it jumped up on my kidney, and then my liver, and then my lungs, both of them. It's been 7 years for me. That's a lot of digging deep. That's a lot of what am I going to do if? And then you realize what am I going to do if is completely irrelevant, because you need to just take it one day at a time, that one emotion at a time. Fear can be all-encompassing, but so can hope. Because of the type of cancer that I have and where it started from, if I'd had the HPV vaccine when I was in my teen years, we wouldn't be having this conversation right now. It would have saved me from battling cancer. Get your pap smears done and pay attention to the signals your body is giving you, because it honestly could save your life. Something somewhere in the planets aligned, misaligned, did whatever they did, tricked my brain into a year earlier. If I hadn't have had that happen, we wouldn't be sitting here right now, because my cancer would have taken over unbeknownst to any of us, or it would have been too late, and that would have been the end of it. End of me. That's how that would have worked out. Get screened for cervical cancer. It's not that bad. It's not that bad. Cancer's worse. Cancer's worse.
Thank you, Shannon. You know, for those of us providing healthcare, and really, Jane's story is just really the story of an individual who ended up with cancer and recognizes the importance of HPV immunization and screening. Now, needless to say, in the continuum, that's really why we're all here today. Shannon, can you go to the next slide if you can?
I think you'll have to re-share your screen, Dr. Roth.
Okay. Do you have it now?
Yep, that's perfect.
Okay. This is the YouTube link. And if you want to share it with your clinics, that would be and other professionals, it would be very valuable. Now, needless to say, why we're all here is screening is so important. And, you know, just yesterday we heard on the news that drinking just 2 alcohol beverages over a week increases your risk of cancer. And we know that tobacco has been a vector for cancer for such a long period of time. Now, whenever I see my patients, women's health population, I tell them what usually is going to get them is breast cancer, cervical cancer, and colon cancer. And there's no reason why the individuals of Ontario aren't being screened, except for human resource issues. But it really should be in the forefront of our discussions with patients every time we have an interaction. Now, we know, just as Jane has said, that in North America, virtually 100% of cervical cancer cases can be prevented with really the two-prong approach of HPV immunization and pap smears in a timely way. If you look at the colorectal cancer experience, the idea of increasing fiber in your diet, weight control, active behavior, cutting down on red meat, and screening will also have such a great impact of colorectal cancer. Now, many of us have seen patients with throat cancer. Now, most throat cancers are also HPV initiated. So the vaccination even becomes more prevalent and to the forefront of our mind in patients, because sometimes you don't get abnormalities of your cervix, you actually get the manifestations in your throat. Across Ontario, it doesn't only have a burden on the individual patient, but think of Jane, her family that's around her, how it impacts her grandchildren, how it impacts her partner, and the impact on the generations to come. And with 583 individuals diagnosed and 155 deaths in a year, many of these deaths can be prevented with timely screening and prevention. So what's the goal? The goal of a screening program is to follow the guidelines. And the guidelines are a little bit of a shifting and changing landscape. The reason why it's a changing landscape is it's very uncommon to get cancer less than 25 years of age. And therefore, the initiation of cervical screening and HPV testing is approaching 25 years of age. So really, there's no reason to do pap smears or HPV testing on those less than 25 years. In the US, HPV testing initiates at the age of 30. The screening interval with a low-risk individual is actually every 3 years if the screening test is negative. And currently the thought is that at the age of 70, if a person has 3 negative cytological results, then you can go to routine, in the previous 10 years, then actually you could stop screening. The idea of 3 negative cytologic tests is because the sensitivity and specificity of a pap smear is 70%. So therefore, if you take 100 individuals, you eliminate 70, then you're left with 30 individuals and you eliminate 70%. Then actually you're left with 9 and you eliminate. So 98% of the individuals really have nothing. And so the idea of doing that is really from a public health perspective, with knowledge that the incidence of cancer over the age of 70 is generally minimal. That's the idea of cessation at the age of 70. This may actually, this ceiling may go up over time, because as people live longer, that may change. Now, if we had to guess, you'd think that with the information in Jane's story, you'd think participation would be over 90%. Participation in our region is 52%. 52% means that individuals are getting the pap smears at the right place, at the right time, and the right treatment. And we're at a participation rate of 52%. And now every area of the province has unique cultural and participation rates. But in our region, 52 is actually one of the lowest participation rates in the whole province. And the idea of the pandemic influence, one would actually expect that the rates of screening would go down during the pandemic, and then there would be an overshoot of the individuals after the pandemic. And as you can see on the screen, there is no overshoot. And that actually reinforces the idea that really we're missing our targets on individuals who are able to be screened. So therefore, if we miss the low risk individuals and the high risk individuals, then we're actually missing patients who can actually evolve to cervical cancer. And those high risk individuals are not being treated in a timely fashion. So we have a two-prong issue. One is that individuals who actually are at risk may not be screened. And those individuals who are at risk are not, when they are screened, are not screened in a timely fashion. So over the years, we spend a lot of time, and especially in Ontario, people do a lot of debating on what the barriers are to cervical screening. And we looked at the data over the last 20 years. And actually, cervical screening was higher about 10 to 20 years ago. And cervical screening has actually diminished over the last decade. And some of these barriers are personally identified barriers. They are cultural barriers, but we're in a dynamic population. And a dynamic population means that not only the Central East Regional Program, but physicians have to adjust to the patients that we service. Otherwise, we'll become obsolete. So if you look at it, when the patient population changes, we have to adjust. And we should be an agile group of practitioners adjusting in a timely fashion. So number one perceived barrier is difficulty navigating our healthcare system. Well, I know that even physicians are finding it difficult to navigate our healthcare system. So our job as leaders, which we all leaders, should actually simplify the process. So the application, when you get an abnormal PAP, is so simple that you actually understand what you're doing and who you're sending the patients to. It's communication, distribution of information, and the lack of knowledge and misinformation allows us not necessarily to put the patient in the right hands at the right time. Lack of family doctors, lack of effective engagement at every level. And this could be the level of the whole system, from the pharmacist, from the frontline individuals, which we are, and the nurse practitioners who endorse and participate in the program, to the leadership at CCO. We have to engage and engage and engage and be agile and get to the right patient at the right time and find ways to engage these individuals. Embarrassment. Embarrassment could be of the provider, of the patient, whether it's cultural embarrassment or actually individuals come from countries where women's health is at the bottom of the list of activities, and therefore they come to Ontario, and it's still at the bottom of the list of their family priorities. And it's our job to reach out to their children, to their husbands, and actually engage programs that actually really get to the root cause of it and actually facilitate an examination. Fear of the examination. Some people think that male providers impede patients' motivation for screening. And there's no question that it does, but that's actually a small percentage, because as our patient population has changed, the number of providers being male has diminished, which actually is appropriate, but the rates of screening have also diminished. So we have to all work harder, independent of our gender, to actually find a solution. And the idea of the solutions work on everybody's clock. So the idea is we have to provide after-hour appointments, weekend appointments, and availability to improve access. So these are just some of the barriers that we come through, and we'd like to hear, and you could put in the chat, any other barriers that come to your mind, because this is really your input and your valuable discussion. It will actually help us move this forward. So they're high-risk groups that have no provider. They're the clients that have been, and this is actually supported by data, clients over the age of 60, individuals with low socioeconomic status, newcomers, First Nation clients, the LGBTQ2S individuals, clients with a history of sexual abuse, disabilities, cultural backgrounds, English not a first language, and with barriers to access. And barriers to access could include something as simple as transportation. So let's talk about doing a pelvic examination. Now, for the providers, I always say that when we become physicians, our job is to take care of the whole patient. And right now, we don't have gender-specific lines of treatment where female physicians only take care of female patients and male physicians only take care of male patients. So therefore, it's the responsibility of that crossover to ensure for male physicians to ensure that their female patients are getting the best screening possible. So how do you do a comfortable exam? So first of all, what you do is communication. The idea is you're preparing the patient before the event that they're doing a pap smear. The idea of separating the interview from actually doing the examination. So I never have a patient who's already changed on the table when I walk into a room. I always discuss with them what we're actually doing on that examination. And I go through with them the details of the examination. What you need is before the patient comes into the room, you need the right environment. You need the right equipment. Now, what I do is I always have the gloves, the speculum, the cyto brush, the light all set up before the patient comes in. And I actually tell the patient the whole step of their history, explain to them what's going on, get a verbal consent, and provide privacy. In each exam room, I have a sign to say that they're able to have a female individual on every examination that I do. And the other opportunity is if they come with a family member, their family member usually may be in the room at the same time. And they're actually a built-in chaperone. So all these little things actually make a difference. So even with the sign that I have on the wall, usually my patients, I personally don't have a chaperone, and my patients maybe one a year actually asks for a chaperone. Now that may be a self-selection process. That's because they see me and they know me. But also, I try and also identify individuals who may be stressed and anxious over the event. So therefore, I never do the event when somebody's stressed and anxious, and I give them options and opportunities. Now, during the examination, we communicate effectively. What I try and do is I use a distraction technique by actually talking them through the whole examination. And many of you do that already. I wash my hands. I tell the patients that I'm washing my hands. I tell the patients that I'm putting gloves on my hands because, as many of you know, I've been involved with the college for a number of years as an advisor. And there's been complaints where individuals perceive that their physician did not put gloves on. So I actually show them that I put gloves on. I tell the patient when I'm in that area and what they should expect. I have 3 or 4 different sizes of speculums, and I always use the smallest speculum that I think could achieve the goal. So I have different sizes for individuals who haven't had children, different sizes for individuals who are menopausal and not sexually active, different sizes for somebody who are grand multips. So the idea of having different tools for your examination is really important, because if you use a large speculum on an individual who has just become sexually active, she'll never forget that examination, and it'll create needless anxiety. So the idea of using the right tool for the right patient at the right time is so important. The special screening circumstances are subtotal hysterectomies, and sometimes you don't know if they had a cervix or not. And sometimes the only way to tell is to look, or to actually do an ultrasound to see if they have a cervix. Pregnant women. Again, an individual who hasn't had a pap smear, what I usually do is I do it in the second trimester, or I give them the option of doing it after the delivery. And I document in the chart that they're picking one or the other. Now, from years gone by, where we used to actively treat individuals with high-grade lesions when they were pregnant, we've actually become more sensible that we actually treat them after the pregnancy. So there's very few instances where you'll treat a patient for an abnormal pap during pregnancy. Same-sex partners, transgender patients, if the cervix is retained, they have to be screened according to the guidelines. And immunocompromised individuals should be screened annually if they're 21 years old, starting at the age of 21. Now let's go over the idea of HPV. HPV, it's a family of viruses, and it's become more prevalent. There's over 100 different types. And 80% of us on the call have had HPV at least once in our lifetimes. It actually started off with the idea that it was a genital virus. And as we know, and I know at least 3 stories of individuals with throat cancer who have been treated with HPV positive throat cancer. And as you know, Michael Douglas also has been treated. So we have to think of the importance of vaccination. Any patient is a candidate for vaccination, even though the guidelines are restrictive. If you're sexually active, and especially if you're concerned about throat cancer, HPV vaccination should be on everybody's mind. Now, it took a while for us to get the boys to get vaccinated in grade 7, but now all boys and girls in grade 7 are vaccinated. And if they aren't vaccinated, they should actually go to their public health units, their parents, and actually ask them if they can actually fill in that gap, especially post-COVID. Now, HPV testing is the gold standard. Why? Because its sensitivity and specificity is so high, and it's been around for almost 2 decades, that if you have HPV testing that's positive, you have the virus, and if you're negative, you don't need to do anything. Now, remember, of those 80%, most of them actually go away on their own, and that creates the pillar of low risk. So HPV is the future state for cervical cancer screening, and it's available in most provinces to all patients. Hopefully the rollout will be over the next couple years. They're still trying to put together a program that's effective. And like we said, it reduces unnecessary colposcopic examinations. Now, I want you to think of colposcopy a little bit differently than you have in the past. Colposcopy is supposed to be an episodic event. In other words, a high-risk patient goes to do colposcopy, and then they're bounced back if they have a family doctor. Over the years, colposcopy has been a continuous event for the colposcopist, and we're trying to shift it back to an episodic, or you just go when there's a problem event. And that needs everybody to contribute to the discussion and education. HPV testing is in the same swab that you use, or same brush that you use for a pap smear. Now, the natural history, as you can see above, is that it infects the cells more like a wart on your finger. And it's the ones to the right. And look at the timeline. This is what this slide's supposed to exemplify. The timeline, HPV-infected cervix takes 1 to 10 years to become a CIN3, followed by invasion. But most of them are actually benign lesions. And this shows you right now, one of the things in Ontario that we struggle with is we do a lot of the high frequency, low risk events over and over again. But the patients who need to be screened are not coming to the table. And it's the low frequency, high risk events that we have to focus on. And now I want you to look above the line of high grade squamous intraepithelial lesion. That's the HSIL. The atypical squamous cells, HSIL, cannot be excluded. The atypical glandular and cancer. Those are the ones that have to go to colposcopy immediately. And you'll see on the subsequent slides, those are the high risk individuals. Now, if you want to think of this as 4 pillars, but I like dissecting things to make them simpler. So the ones that are normal are the ones that end up going return cytology every 3 years. So look at the left of the chart. So that pillar on the left is normal, and that goes to cytology. Now, ASCUS, it's a little bit of a confusing terminology because there's ASCUS with nothing after it, and then there's ASCUS, rule out high-grade lesion of the cervix. So it's a little bit of a confusing terminology because once they put that little H at the end, it moves right over to the right pillar. So you can see it says ASCH. Now, the number of individuals in Ontario, and you can put in the chat your guess on the number of physicians who know that ASCH is different than ASCUS, is I'd like to believe that it should be close to 90%, but it's about 25% of individuals know that ASCH is the same thing as HSIL. Okay, so needless to say, these webinars are important, even if you get that out of it. So it goes into the high risk area, okay, where ASCUS means they couldn't tell what was going on in the PAP. So therefore, if it comes normal, you go back into the normal every 3-year group. But if you get ASCUS twice, it means they can't tell what's going on. You go back to colposcopy. Now let's go to the right half of it. LSIL means you have the virus. You repeat the cytology in 12 months, it's normal. You repeat the cytology in 12 months, it's normal. Now you go back to the normal screening. But now you get an ASCUS. So 2 low risks put you into a colposcopy group, and you become a high risk. So 2 in a row put you into a high risk group. Now the high risk, if you look over to the right side, gives you ASCH, HSIL, AGC, and AIS. And this actually goes through it in a different format. And this is just like I showed you, and you're going to get a copy of these slides. This is the low risk group, and this is the high risk group. Now, the idea is that every physician or nurse practitioner should be able to do pap smears. And the idea is that medical directives is the concept of force multiplication. In other words, you're using other individuals' skill knowledge to actually support them in being effective. Delegating services promotes patient safety. It facilitates timely care, and it contributes to the optimal use of healthcare resources. Now, we have everything from pharmacist assistants to physician assistants, midwives, nurse practitioners, And they can all contribute to actually the discussion of screening and, more importantly, the physician assistant, midwives, nurses, and physicians to the application of screening. So medical directive in primary care, there's no excuse that if you have a nurse or a nurse practitioner, they can't be involved in we put together a program, our team, on actually educating frontline workers on how to do a pap smear. And we invite everybody on the call. If you need a refresher, sign up and we'll get you in as soon as possible. We may even come out to your area if you get enough individuals, and we can actually remind you how to do a PAP effectively, and that's what we're here for, to support you. The idea of force multiplication and delegation allows us to use our artificial intelligence, our EMRs, to look for overdue screening, to book screening appointments for our patients who can't or aren't screened, to screen the patients, and we're always here for result management. Now, individuals for colposcopy are one of the problems with they're taking too long to get to colposcopy. So the goal is, if your patients are taking more than 2 or 3 weeks to get to colposcopy, you could reach out and we'll actually find a colposcopist who will meet and exceed your expectations. So in summary, this individual on the right is actually this little cute little child is actually produced through artificial intelligence. It's not a real child. And what does that tell us? The use of artificial intelligence can actually achieve wonderful things. And we're going to try and work together with you to develop an application to simplify cervical screening. But I want you to think of cervical screening that every eligible patient, which is most of your patients are eligible, should have screening. You have to divide it into low risk and high risk groups. ASCH is a problem. Think of it as a high risk group. Wait times are unacceptable, and we all have to work to bring them down. And you can always reach out to me to get more timely services and the team. Follow-up is the most important thing, and it's our responsibility as stewards of this system to make it more effective. So we're always available to talk about any women's health issue, especially with cancer prevention, and we could have another follow-up webinar, and if you would like us to do it. Now it's time for questions, and I'll let Shannon handle the hands up.
Thanks, Dr. Roth, an excellent presentation. I'll first maybe pop to the chat. We had a few questions about Jane's video. I did reply in the chat that I'll be very happy to share that around with everybody. We're just working on some of the final transitions and smoothing things out. So as soon as we have that finalized in the next week or so, I'll send it by an email for that YouTube link. We had a question from Roseanne that says, my concern is we have young people who are sexually active from age 14 or 15 and they aren't vaccinated for HPV. Aren't we missing opportunities for screening? I think by starting at 25 was the context there.
So it's an important question. Now remember, guidelines are just guidelines, but let's give you the stats. The chance of getting cervical cancer at the less than 25 years old is virtually zero. It's very, very uncommon. Now, these individuals should be screened for sexually transmitted infections. One of the things about starting screening at the age of 25, we have sexually active individuals who actually are getting everything from trichomonas to gonorrhea to chlamydia to LGV, and they're not being screened and they're not seeing anybody. And you have to remember that these are guidelines. So if you feel that you want to do an HPV test on this individual and clear them for 3 years, you can do that. But remember, the idea is they probably won't be treated and will have to do another pap smear in a year anyway. So the guidelines really don't support the idea of doing pap smears on 14-year-olds.
We had some others contribute to the conversation around barriers. So language barriers, lack of welcoming spaces and knowledgeable staff on gender non-conforming people, lack of knowledge on transgendered experiences. Transportation is another barrier, childcare, and in small communities, there's a fear of confidentiality breaches. Few other barriers to list here. So healthcare providers using language or terms that people don't understand. Oh, using terms that people will understand and not medical terms. I think that's an important one, certainly to make sure you're speaking in a way that patients can understand. A few more points here. Unattached patients have different medical staff each time the client has an exam. They're not understanding the importance, process, and or correlation between screening and long-term outcomes. Some barriers that were contributed. Now we have another question here. If someone has never been sexually active in any way, shape, or form, Ontario cervical screening guidelines say defer PAP until sexually active, even if over 25. Is this different from American guidelines, and is this correct?
So if you're not sexually active, the idea that you should not be exposed to HPV, therefore you're not really at risk. And that you can actually, so that's the guideline. Now, in the US, actually, they do HPV testing, and the current guideline says starting at the age of 30. So they still support the idea that they may not need any HPV testing. You see, they've already gone beyond the pap smear in the US. They either do co-testing, that's HPV and a
Dr. Roth froze for me. Did he freeze for others?
Yes,
Yeah.
I believe he's frozen.
Okay, thanks.
And in a very flattering position, actually.
Yeah, always the way when you freeze, right?
Always the way.
Definitely, definitely. I think what he was talking about there was the in the States there is co-testing. So in many states they're doing HPV testing and a PAP at the same time to compare results. Ontario is moving to just the HPV testing. So there you are, Dr. Roth. Sorry you had frozen, so I was trying to cover for you. You seem to be back.
Oh yeah, I don't know, internet, the most reliable, unreliable activity. So the optimal time to do a PAP postpartum is when you have the chance to. So after 6 weeks, that's the idea. So I do it. So I see actually now postpartum patients, actually I speak to them on the phone in 2 weeks. In the US, they've moved to the idea that you really influence the patient by giving them some support 2 weeks after their delivery. And I picked up people with wound infections or whatever. So I see them 2 weeks later. But 6 weeks is a reasonable time because you have involution of the uterus. And I would think of it as an opportunity to do a pap smear because I want you to think of the idea that pap is going to become the word HPV testing. And if you could do HPV testing on your patients 6 weeks postpartum, you're doing them a real favor. So I think that 6 weeks later, I would do either an HPV test when it's available or do a pap now. Now, ascus, sometimes you end up, it could be yeast, it could be something else. But if you look at the current guidelines, they take that into account. So you could repeat the pap in a year. So it really is an opportunity for follow-up. Can a patient pay for a HPV test? The interesting thing, so it's actually on the same brush. So they call it reflex cytology. So you can actually process that HPV test within 30 days by just letting the Life Labs or Gamma Dynacare know that the patient wants an HPV test. And therefore, they'll still do a test on that PAP. And if that HPV test comes back negative, even if the PAP says low grade, it means they have nothing because the HPV test is more accurate than the cytopathologist looking at the slide.
And I'll just add, sorry, oh, there was a question there. The cost is $90 right now to the patient for the HPV test.
And the lab bills them directly, so you do not have to handle the money because everybody thinks it's going in your pocket. But no, it goes right to School vaccines have fallen off the radar during the pandemic, and because it wasn't a priority. And the best advice is to speak to your public health unit first and find out what they can actually, well, I always say there's two-pronged. Find out and tell them what you expect. Find out what they're currently doing and tell them you'd like all your patients during the last 2 years to be immunized. And you think the only fairness of the whole thing is to get them immunized at no cost because the last 2 years has been a disaster for everybody. And say it's unfair for them not to be immunized. So I would do it as an information gathering experience, but also tell them what your expectations are. Because needless to say, 2-year gap is a significant gap, and it fell off the radar. So the numbers that have gone down so significantly, they were going at about 70% before, they dropped to possibly half that. Now, what do you recommend that for? So HPV, I'd recommend for the individuals who want to spend the $90 or for the individuals who had either ASCUS or LSIL on their previous PAP and can't afford the 90, but in a year's time, they could afford the 90. So therefore, you tell them the next time you do a pap smear, you're going to do it with HPV testing. So therefore, if that test comes back negative, now you're in that low risk group. And if it comes back positive, you flip over to the high risk group, and then you send them for colposcopy. Any other questions? They get a receipt from LifeLabs, and the insurance should actually cover it because it's a medically indicated test. And most patients, if you suggest HPV testing to help sort out their issue, they will actually choose to do it. Now, one of the reasons why I find it very useful to when somebody has LSIL or ASCUS on a pap smear to either do HPV testing that time or in a year is because when they apply for life insurance, they have to write down that they have an abnormal pap. And I don't like individuals walking around thinking they have an abnormal pap if they're HPV negative and somebody says they have ASCUS. So I like to know whether they're HPV positive or negative. It is HPV vaccine covered by benefit. It's a medication. It's covered by many plans, and it depends on what benefit plans you have, but it's covered by most plans. It's actually covered by the physician plan. So many of you physicians in the audience, actually, who are considering HPV at a more senior age, it's actually covered. There are issues getting results from Pap tests in a timely way. Are there any issues with HPV results from commercial labs? Now, one of the reasons why there's a gap in the timeline is because they took the cytopathology technologists and moved them elsewhere. And also there was always a shortage. Now, this happened about a generation ago also. One of the ways to get your patients through the system more efficiently is right on the requisition urgent, because it is urgent for that patient. And therefore, they get the HPV result and the pap smear more effectively and efficiently. And I think that my own personal view is it became less of a priority because pap smears are done on women. And I think that we have to remind them that pap smears are an essential part of screening, and that by me putting urgent on the requisition means that I'm expecting a timely result. In the last 5 minutes, any other questions?
Just one there about what's the process for adding HPV after the fact on a previously done PAP?
You just get the approval of the patient, and then just call the lab, document who you speak to, and tell them that you want them to do a HPV test on that specimen. Any other burning questions about, how many of you use different size speculums? How many of you have 4 or 5 different size speculums? It's very important. And they're you know, nowadays you can actually buy them cost effectively. And in a lot of the menopausal individuals who aren't sexually active, I actually use the pediatric speculum. It allows them to actually want to come back and do another pap smear. So, so again, pick a smallest one you can use, and then if that doesn't work, go one size up, and then inform the patient. Now, another pearl is if you can't see the cervix, take out the speculum, and what you do is you use a digital exam to find where the cervix is, and it helps you identify where to go with your speculum. It's good to have a combination of metal and plastic. Plastic's horrible for the environment, and metal leads us to do a lot of processing and, you know, in the autoclave. But you know, I think it's good to have a variety of sizes and applications. Any other questions in our last couple minutes? Well, first of all, I want to thank everybody. First of all, I want to thank the team at Cancer Care Ontario for helping put this all together. These are meaningful opportunities. We hope to have more bilateral discussions and have you contribute more, because you have to tell us what you want to make you successful. Okay, because your success is intertwined with our success and the patient's success. So we can only be successful by having a good, positive dialogue. Shannon, I'll let you take it from there.
Yeah, thank you so much, Dr. Roth. Great presentation, and I think everyone's putting in the chat how much they've appreciated your talk. I'll just ask if you're signed in with just a first name, if you would put your full name in the chat so we can create the certificates of attendance for those seeking accreditation credits. We can make those properly if we have your full name. If you can see your full name in your sign-in, then we'll just use that to make the certificates, and you should have those shortly. And we'll share around the video link for Jane's video, as well as a video link to this presentation so that you can reference any points of it. Thanks again, everybody.